It's quite a pleasure to see you guys here and to speak to you about, I'm going to speak to you about anemia. From most of the questions that you submitted were related to anemia and blood disorders. Anemia is one of the most common diseases affecting the entire world. There's maybe as many as 2 billion people in the world who suffer from anemia of some sort or some type. The first slide, however, is and all of you have heard the joke of why the immune scanner carries the 2x4. 2x4 here. What it is, does coffee cause cancer? Think so? No. There, all you had a cup of coffee this morning? Yeah. That's my 2x4. Okay, all right. That coffee, there is some evidence, statistical evidence, that coffee causes cancer of the esophagus and of the stomach. You look at coffee, it has no carcinogens in it at all. There are no carcinogens in coffee. But there's a statistical relationship to cancer, particularly of the GE junction. And the GE junction is where your esophagus meets your stomach. And the significance of that is that that cancer has a terrible prognosis, equivalent to pancreatic cancer in terms of prognosis. So if there is a relationship, it will be important to establish it. And so it doesn't contain a carcinogen. So how does it cause the cancer? The clue is that drinking iced coffee or iced tea is not associated with cancer. Drinking hot coffee and hot tea is associated with cancer. And the truth, it tastes great in your mouth, but it's scalding your GE junction. And the heat is causing inflammation, and the inflammation appears to be causing cancer. It will require a prospective study to confirm it, but it's becoming even more important as you notice your teenage daughters are now going to Starbucks. They started drinking coffee and coffee drinks, and carcinogens in younger people are more potent than they are in older people. So it's a very important situation. Anemia, and the definition of anemia is a decrease in red blood cells. There are several ways to measure it. Most of you have heard of your hemoglobin, and hemoglobin is synonymous, low hemoglobin is synonymous with anemia. A lot of people come to me and say, I came to see you because of low iron. And they are thinking low iron is synonymous with anemia, but it's not. Iron deficiency is just one cause, hundreds of causes for anemia. But the reason they say that is because when they are seeing their primary care, they say you're anemic, and without doing any tests, they just give them iron. And so they think that anemia is iron, but it's two separate things. Anemia is one of the most common medical order in the world. Most women are anemic all their menstrual years, from the age of 11 to 45 to 50, they are anemic. 50% of pregnant women are anemic throughout their pregnancy. Men have about 4 grams of iron in their body. Women have an average of about 2.5, but pregnant women have an average of 1 gram of iron in their body because they lose 1 gram to the baby during the pregnancy. So it is pervasive. Most women don't realize they're tired or they're fatigued until you replace the iron. If you replace the iron, and they say, well, it's a miracle, but they're just feeling like normal people for the first time in their life. Okay. So the World Health Organization classification of anemia is a hemoglobin less than 13 for a male and 11.9 for women. And we're going to use that criteria. Normally, surprisingly, the organ that controls your blood count is your kidneys. Doesn't make a lot of sense, but your kidneys senses how much oxygen is in your blood. And when your oxygen level drops, it makes a hormone, erythropoietin, and erythropoietin stimulates your bone marrow. And your bone marrow is where blood is made. It's like a factory. And red blood cells, white blood cells, and platelets all have the same stem cell. And what they do, they go in different directions. It takes 7 days to make a mature red cell. So you stimulate it, and the stem cell goes through a series of developments, and it comes out of your bone marrow. Your bone marrow is like a factory. It makes millions of blood cells per hour, not per day, millions of blood cells per hour, because you have millions of blood cells that are dying every hour. So it has to be replaced. Your blood cells last about 120 days, 3 months. Or some disorders like sickle cell anemia, they only last 2 weeks. So the patients have to make more and more blood to make up for the fact that the blood cells don't last that long. Well, what is the purpose of blood? The purpose of blood is two things. Blood delivers oxygen to your body, but it also delivers sugar. You have to have oxygen to burn sugar. Your body is a sugar burning engine. Like your car burns gasoline, you oxidize gasoline, your body oxidizes sugar. And what it produces is electrons. When I do this, I'm using millions of electrons. I'm burning millions of molecules of sugar in order to produce those electrons. Okay. You have to do that continuously. Your brain will only burn sugar. Your brain will not burn protein. It will not burn fat. It will only burn sugar. If you cut off the circulation to your brain, you got about 1 minute of sugar and about 15 seconds of oxygen. And then after that 1 minute, you started your brain damage. And in about 3 minutes, you'll be dead because there you can't exist without the sugar and oxygen. So blood is essentially important to deliver sugar and deliver oxygen, especially to your brain. So blood picks up oxygen in your lung, it goes out to the periphery, to your feet and your toes, but most importantly, it goes to your brain and it delivers the oxygen. The hemoglobin molecule delivers the oxygen, it picks up carbon dioxide, goes back to your brain, your lungs, carbon dioxide comes back out when you breathe. So it's the respiratory cycle. Once again, your kidneys is the sensor. Your kidneys sense when the oxygen is low, and it makes erythropoietin. Your bone marrow, the factory, puts out red cells. If your oxygen level drops like the lower level, and it does when it comes back to normal, the kidney shuts down and doesn't make any more erythropoietin because you have a normal blood count. Anemias, there are multiple anemias, and we classify them by different groups. Nutritional anemia. When I say nutritional anemia, I mean that a certain nutrient is involved in the anemia. There are almost nobody in this country has anemia due to the fact that they don't eat well. They want to separate nutritional anemia from the fact that you're not eating well. The nutritional anemia, people who don't have anemia as well, they're not eating well, are third world countries where they are eating just millet, or they're just eating just rice, or they're eating a diet of constitute where they don't eat the kind of diet we eat in this country. So a dietary anemia in this country does not exist unless you are anorexic. I've seen people from anorexic nervosa who actually have anemia due to a poor diet. And it's kind of amazing, if you do a bone marrow biopsy, instead of having bone marrow, they have this brown jelly in their bones because they have metabolized their bone marrow for energy. They have no other source, so they use up their bone marrow for energy. So you can see an anemia due to anorexia. The number cause of anemia is drinking. Alcohol is a potent poison for your bone marrow. If a person drinks heavily, you do a bone marrow biopsy, you look at the cells, the stems, the cells that they're maturing, they're full of holes. It's what we call vacuolated normally. They have these vacuoles in it. So the cells don't develop normally. The other thing that alcohol does, alcohol is what we call a folate sink. You need folic acid to make blood, but once you start burning alcohol, the alcohol metabolism requires folate. So it takes the folate that you normally use to make blood, and you can't make blood, and so it's what we call a folate sink. It takes away your folate. The other problem with alcoholism is that alcoholics frequently get the majority of their calories from alcohol. Therefore, they don't take in the nutrients that they actually need to make blood. Next group of anemias are what's called hemolytic anemias. In a hemolytic anemia, you're anemic because your blood is breaking up. It doesn't live for 120 days. Like in sickle cell, they live for 2 weeks. And people who have a thalassemia, thalassemia is a combination of a hemolytic anemia and a congenital anemia. Thalassemia and G6PD, sickle cell anemia are all called congenital hemolytic anemia. What they have in common are that they're all West African genes. All are West African genes, therefore they are Afro-American genes because they're West African genes. They are prevalent in the population because each one of them confers resistance to malaria. Although they are potentially detrimental genes, they are increased in the population because if you look at a population, if you study the history of West Africa, the West African are actually started out as North Africans who migrated to South Africa, and they were hunter-gatherers. About 5,000 years ago, they decided they were going to be agrarian. So they did a slash and burn. They slashed and burned West Africa. When they slashed and burned, all of a sudden they had pool on the ground, and had sunshine on pool water, and a species of mosquito arose. And that species of mosquito was a carrier for malaria. So malaria is not the oldest disease in the world, but malaria is the #1 cause of death in the history of the world, more than all the wars in the world. But it will soon be surpassed by cigarette smoking. Cigarette smoking will surpass the number of deaths that are caused by malaria. But malaria is a evolutionary pressure. It pressures you to, if you take an unexposed population of children, malaria will kill 1/3 of the children on their first infection. And the next infection they have will likely kill another 1/3. So in the pressure of malaria, the species couldn't survive because there were progressive death of the children. But these blood defects confers a resistance. Therefore, the number of people who have these defects increases in the population. 1 of 6 of you in this room have a thalassemia. Alpha thalassemia is one of the most common blood disorders. And alpha thalassemia means you're mildly anemic, just a little bit anemic, and you have tiny blood cells. So you have a remnant of your West African heritage is the fact that you have a thalassemia. You have acquired hemolytic anemias. Acquired hemolytic anemias, they spontaneously develop. And ones that spontaneously develop are usually called autoimmune. Your immune system is hyperactive. Your immune system all of a sudden doesn't recognize your blood cells as your blood cells, and it starts to destroy them. Your blood count will be a function of how fast it can destroy them versus how fast you can make them. Some hemolytic anemias are so fast that you can drop your blood counts from 12 down to 2 in a matter of days. And when you're our age, if you drop your blood count from 12 to 2, you're probably going to have a heart attack. And that's one of the #1 causes of death for untreated hemolytic anemias. They're in the ICU, you see that blood count dropping, you see the EKG changing, they have a heart attack. Most hemolytic anemias are not that rapid. Most of them are chronic, and they are treated with immunosuppression because they are due to a hyperactive immune system. The other acquired hemolytic anemia are infections like malaria. Malaria, you think unless you travel to a malaria endemic area, you can't get malaria, but I have one sickle cell kid who got malaria from a blood transfusion about 3 years ago and was quite ill. So you can still get malaria in this country from a blood transfusion. And then you also can get babesia. Babesia is a tick-borne virus, organism that's from a deer tick. It normally doesn't cause anemia in the deer, but it causes anemia in humans because it infects their blood cells. And you can also get babesia from transfusion, and we've had several cases of babesia-related anemia from blood transfusion. Probably the largest category of anemia, and the one that most likely we'll see in you gentlemen, would be anemia of chronic disease, because an anemia of a chronic disease, the anemia is not the primary process. Another disease is the primary process, and anemia is secondary to that disease. Inflammatory diseases like rheumatoid arthritis, almost everybody who has active rheumatoid arthritis is going to be anemic. And everybody who has active lupus is going to be anemic. And the reason it causes anemia is because your immune system reacts to any type of inflammation as an infection. And from an evolution standpoint, most bacteria require iron for their enzymes to work. And once you become inflamed, your body sequesters the iron so that the bacteria can't get it. And so when it sequesters the iron, you can't make blood either because you can't utilize the iron. So a reaction to inflammation is sequestration of iron into the immune system until that inflammation goes away. And if you have rheumatoid arthritis, that inflammation is probably never going to go away unless you're on a biologic and it goes away. And you can actually monitor the activity of the disease. As you come under control from your biologic, then the anemia goes away. And if your anemia, and when your disease is out of control, the anemia comes back. The same thing goes for lupus and most autoimmune diseases. Other chronic infections can also cause anemia because it causes inflammation in your body. Chronic infections like osteomyelitis, infection of the bone. One of the biggies is tuberculosis. Having chronic tuberculosis make you profoundly anemic. Lead poisoning. Lead poisoning is something that you receive very little of, and one of my hematology professor told me an interesting case of lead poisoning, that when he was in Minnesota, that there was a battery plant, and all of the guys in the battery plant were coming in with lead poisoning. So they called OSHA, and OSHA went out and inspected the battery plant and said, everything is right here. Everything is fine. We can't find anywhere that these guys get contaminated from the lead. But then one day, one of the doctors went out, and before the plant opened, and found all the guys warmed themselves around a barrel, and they were using batteries as fuel in the barrel. Okay, renal failure, kidney failure is always associated with, not always, but I'm practically always associated with anemia, because the kidneys are the organ that makes erythropoietin. The kidney is the organ that senses what the blood count is and makes more erythropoietin when you need more blood. So the anemia of renal disease can be seen at all levels, stage 1 all the way to stage 4. You can see an anemia associated with it. Other causes of anemia is bone marrow infiltrations. If your bone marrow is an infinite amount of space, it's a factory, it can make blood very fast. You can raise you can increase the amount of blood you make up to 5 to 10 times normal if you need to. But it can't do it if there's something else in the bone marrow taking up space. And one of the things you can see in people, especially people our age, is that you can see metastatic cancer. The two cancers that you can see most often in the bone marrow for people who have this unusual anemia is prostate and breast cancer, both of which have a tendency to go to bone. And if they occupy enough space in your bone, you won't have enough space to make blood. The other disease that can infiltrate your bone marrow is actually a part of the bone marrow itself. It's multiple myeloma. Multiple myeloma is a cancer of an element of the bone marrow. Multiple myeloma is essentially a black disease. Multiple myeloma occurs about 3 times more common in black than it does in any other race. I don't know why. Okay, but Atlanta is a hotbed for multiple myeloma. At one point, I was treating 3 ministers of the largest Methodist church in Atlanta, and they all 3 had multiple myeloma at the same time. And then something I've noticed, and I don't know why either, but a lot of my myeloma patients tend to be Methodists. I don't know what they're doing. I don't know what they're doing too. But the thing, okay, I'm not saying that because I'm a Lutheran, but I'm just saying, okay. The other things that can occupy your bone marrow is leukemia. And leukemia sometimes will present only with anemia. The bone marrow will be packed full of cells, and you won't see any cells circulating in the periphery. But when you do the bone marrow biopsy, when you're thinking the person just maybe has anemia or chronic disease, you're surprised that they turn out to have leukemia. Lymphomas can also do that. Lymphomas can start in the bone marrow and just pack it so tight that your hemoglobin goes down as a result of being infiltrated by the lymphoma. There are also bone marrow failure states that are not necessarily because the bone marrow is infiltrated or packed. One of them is aplastic anemia. Aplastic anemia is a disease of people of all ages. Aplastic anemia is a failure of the stem cell. You have millions of stem cells, but one stem cell dominates. That's the one, all of the blood cells, your red cells, your white cells, your platelets, are the daughters of this one mother cell. If you did a stem cell transplant, you could take out and freeze millions of stem cells to transplant back later. So how could this possibly happen that all of a sudden you have no stem cells? And there is most people believe it's because you're mounting an immune response to your stem cells. And one of the treatment for aplastic anemia is to use immunosuppression. The other way to treat it is to require the bone marrow biopsy. If you don't respond to immunosuppression, then you have to transplant someone else's stem cells in to regenerate your bone marrow. Pure red cell aplasia is a type of aplastic anemia, which only red cells are affected. And I've seen it only one time, and it's usually sometimes associated with a tumor called a thymoma, that you can have pure red cell aplasia. There are chronic disorders that affect your bone marrow, and some people in this order more than likely to suffer with these. These are called myeloproliferative disorders or myeloproliferative neoplasms. One of the most common one is thrombocytosis. That is, you're making lots of platelets. Platelets are the cells that make your blood clot. You're making lots of platelets that you don't need. The normal platelet count is about 150 to 350,000. In thrombocytosis, it can get up to 3 million. It just keeps going up and up and up and up and up. It would seem like, since platelets help your blood to clot, it seems like it would be a good idea because you wouldn't bleed to death. But they clot when you don't want them to. That's the problem. And people have this disorder, have events. The majority of people with essential thrombocytosis that I may have had when I was doing oncology, as many as 80 people with this disorder, have no events at all. Their entire life, they're just coming to see me, and they can't even figure out they're coming to see me because nothing ever happens to them at all. But when they do have an event, it's a disaster. It's a heart attack or it's a stroke. So you have to treat the disease. Currently, there are people who, the Mayo Clinic is recommending not treating people below the age of 60 for treating them, for bringing their platelet count down. But my experience is that about once a year, I would see a 30-year-old or a 29-year-old who had a heart attack. And when I checked, the platelet count would be 800,000. Or I see a 30-year-old with a stroke, and the only abnormality we can find is platelet count is 600,000. So I believe that everybody with this disorder, maybe just African Americans, don't have improved, but I think everybody in this disorder should be treated. You treat it with two things. You treat it with aspirin, because aspirin is an anti-platelet drug, and it keeps the platelets from being sticky and spontaneously stick together. And you put you on a medicine called hydroxyurea to bring the platelet count down. Okay. The other myeloproliferative disorder is polycythemia. In polycythemia, you make too many red cells. And when you have too many red cells, it seems like if you were doing the Tour de France, it would be to your advantage. But if you're not doing the Tour de France, it puts you at risk of strokes and heart attacks because your blood becomes too thick as you make too many red cells. And we put you on hydroxyurea, or we send you to there's only one facility in town that is Life South, to do phlebotomies every month. You go there, they take blood from you, and they take the blood to keep your blood count down to a normal level. Okay. The third myeloproliferative disorder is called chronic granulocytic leukemia, and it is just that, a chronic leukemia, and it's a leukemia that's slowly developing. Up until about 20 years ago, it was almost universally fatal. That you get to leukemia, and I had almost no symptoms at all, but it was suddenly changed from chronic leukemia to acute leukemia. And immediately when it became acute leukemia, there was no treatment that would make any difference at all. But about 20 years ago, we developed the drugs called tyrosine kinase inhibitors, and now almost 90% of patients who have this disorder will live for decades. We're not sure if they're cured, but I believe that they're cured as long as they're taking the medication. Okay. Another disease that we're concerned about, and particularly in people our age, is something called myelodysplastic syndrome, or MDS. A myelodysplastic syndrome is common in patients over the age of 70 years old. It can occur at almost any age, but the older you get, the higher risk you are for a myelodysplastic syndrome. And a myelodysplastic syndrome, instead of having a loss of stem cells, you have a defective stem cell that takes over your bone marrow. It will not mature. I told you that it takes 7 days to go from the stem cell to a mature cell. Well, it may go to stage 1 or 2 and stop. So the factory, instead of putting out millions of blood cells every hour, it drops to hundreds of thousands, it drops to hundreds, and sometimes it drops to zero. So you have this progressive loss of ability to make blood. It not just affect your red cells, but it can affect your white cells, it can affect your platelets. And and the other problem with it is a pre-leukemic disorder. If you have an MDS long enough, you will subsequently develop leukemia. So MDS is a disorder of the bone marrow. It's a disorder that is very prevalent in people our age, and it's something that we are always looking for. And the treatment frequently requires chemotherapy, and the decision always comes down. I see people, they send them from the nursing home. They're 85 years old and they have an MDS. And I can tell from the blood smear that they have an MDS. And the decision is to what are you going to do with an 85-year-old with an MDS? If you're not going to give chemotherapy, then I don't even do a bone marrow biopsy. I don't really need the information if I know they're not going to get chemotherapy. And so it's a matter of just transfusing them when they need to be transfused, give the cells what they need to be for it, and I don't work it up any further. Okay. The last group is anemia of the elderly. Anemia of the elderly is a wastebasket for when you can't find the answer. You got an old person there coming to see you. You've done all the tests. You did the bone marrow biopsy. You did all the blood tests, and you can't find the answer. And you say, it's because you're old. Okay. That's right. Okay. All right. Well, the good thing about the anemia of the elderly, it tends to be slowly progressive. It tends not to require any treatment at all. And, all right, back to another 2x4 here. Okay. And it has nothing to do with my lecture, but I know y'all want to know the answer. Okay. Is exercise as effective as Viagra for ED? What'd you say? You're playing me now. I don't really believe that. But it's true. In a trial, aerobic exercise, 30 minutes a day, 3 times a week, was just as effective as Viagra in terms of reversing ED. So this study came out in August. I've been walking every day ever since. Okay. That's right. Okay. And so one of the key points is that the people who were the most severely affected ED had the biggest gain as a result of it. The one caveat of this study is they probably should have had the wife fill out that second. And the reason is surprising, but it's not surprising. ED has the same cause as heart disease. You used to be able to run up the stairs, can't run up the stairs no more. The same thing happened with ED. You used to be able to do things you can't do anymore. If you get back in the condition, you may be able to run up the way you can walk up the stairs. Okay. But the other important issue is that ED in a person who doesn't have a neuropathy like diabetes may be the first sign that you have significant coronary disease. And if you have ED, you should not only see the urologist and ask for those tablets, you should also see your heart doctor. Okay, there's a series of tests we do for anemia, and one of the most important tests from my standpoint, other than doing levels of B12, folate, is to do what's called a reticulocyte count. And a reticulocyte count, a reticulocyte is a new blood cell. The blood cell that just born, just popped out in the dirt. When it turned out, instead of being red, it's slightly blue. And you can look at it in a microscope. And I'm one of the few people who actually go to the lab and look at a microscope. When I was attending the residence at Atlanta Medical Center before they closed, they didn't even know where the lab was. They'd never been to the lab. They never been. So you will look at it under the microscope, you will see these blue cells, and these are new cells. Normally, your reticulocyte count is 1%. 1% of your cells. My sickle cell patients have reticulocyte counts of 18 to 20, meaning they're making blood 20 times normal, and that's the only way they can maintain their blood count because their blood is constantly being destroyed. So reticulocyte count tells you how fast your blood is turning over. So you can group anemias in whether they have a high reticulocyte count or a low reticulocyte count. In group 2, these are called hyperproliferative anemia. That's an anemia with a high reticulocyte count, meaning you can look at the blood smear, they're making lots of new blood. And almost that's because their bone marrow works. The only way you can make new blood is that your bone marrow is working. So it's not a bone marrow problem. You already know that. It's a peripheral problem. It's a problem with consumption. Either you're hemolyzing, your blood cells are breaking, or you're bleeding. So if you fell and hit your head, you bled significantly, in about 3 days, your retic count will go from 1 to 5. You start making blood, not to make up for it. So when you see a person and you do a blood count, and you do that in the retic count, and the retic count is high, you're thinking they're bleeding or they're hemolyzing. They're breaking up the blood in circulation. The other group is hyperproliferative anemias, which the retic count is low, meaning their bone marrow is not working for some reason. It's not working. It could be not working because they have a deficiency, like iron or B12, or it could be not working because they have cancer. And inside the bone marrow. They have leukemia, but they don't make they make no attempt to correct the anemia. They have a hemoglobin down to 6 with no new blood cells, meaning that for some reason the bone marrow is not working or it's not responding. Okay. I know y'all got this box in the mail from the insurance company, and when you saw your doctor and you asked him about your colonoscopy, you said, "Oh no, let's take this box." Okay, you go home and send in the stool specimen. So you got your Cologuard box, and the question is Cologuard the best way to prevent colon cancer? Oh, you guys must have already had the lecture. Okay. No. Only colonoscopy prevents colon cancer because you have to remove the precancerous lesion to prevent the colon cancer. You don't remove anything by doing it. Cologuard is actually very good at detecting cancer. These are the development tests for screening for colon cancer. On your right side is the FIT DNA, that's your Cologuard. On the left side is your colonoscopy. You can see that on the left side of the colonoscopy, you can pick up polyps all sizes. And if you remove those polyps, you hope that 95% on the purple will disappear because you have removed the pre-malignant lesions. If you look on the Cologuard side on the left side, the Cologuard is very good, 92% efficiency in picking up cancer, but it is not very efficient to tell you that you have polyps. And there's no way you can remove those polyps because it's a non-invasive test. What is interesting is the CTC. You see the CTC in the middle? And that is a CT colonoscopy, which you probably never heard about it, never seen it because the GI doctors are lobbying against that test. Okay, this is a test where you can do your colonoscopy using a CT scan. It requires no prep. You don't have to have diarrhea. You just walk in, you get to see the colonoscopy done, and it's pretty efficient in terms of picking up polyps, the fact that you have polyps, and the fact that you screen you for cancer. But like I said, it's not locally available because I think there's some lobbying going on, okay? Symptoms of anemia. If you became acutely anemic, you had surgery or you had a gunshot, and you lost half your blood volume, you would be weak and you would be shocking. Your blood pressure would fall, you'd be short of breath, you can have chest pain, you can have dizziness, and you can faint. And that's what's happening when you're acutely anemic. You become hemodynamically unstable. But most people are chronically anemic. And it depends, your symptoms depend on how long it took you to become anemic. Most menstruating women are very anemic. Sometimes the hemoglobin are in the 4s. If I see them all day 4, 5, they come in, haven't got a symptom in the world at all. You have to pull it out of them that they are tired and fatigued. The reason they complain of being tired or fatigued, they've been tired and fatigued since they were 16 years old. They've been tired all the time. So it's a normal way of life for them to have. The reason they come to see me because they went to see some doctor. They said, "Oh, you need to go to emergency room. Your hemoglobin is 4." Okay, but they can run up the stairs. They can do whatever they want to do, but they are totally, because their anemia has been long-standing, slowly developed. They have very few symptoms as a result. But if you have anemia for iron deficiency like they have for a long time, you have headaches. One of the things that you ask them, almost universally have bad headaches and nothing works. Most times you take a leave, nothing works because the headache associated with the anemia. The other thing that they have that is peculiar to iron deficiency is a pica. A pica is a craving for something that's really not food. Okay, and one of the most common things is ice. And when I look at patients, I always ask them the first question: is it racetrack or and most of them, they can't get to race. They love racetrack because it's so tiny. But if they can't get to racetrack, they'll take their other ice and crush it and make it tiny. It's something about the crunch that they want. So they eat clay, they eat starch, they eat hard candy, but it's the crunch. And some evolutionary wise, it's forcing them to crunch. And so they seek this crunchy thing. Sometimes it's kind of amazing. They will eat starch, they will eat baby powder, and something, and this is humorous, but it's sad. Sometimes when they're talking to me and they're opening first and the starch will fall out. So it's really a major craving, and it's kind of amazing that when we give them intravenous iron, sometimes the craving goes away the same day. same day they get the iron, the craving this late. And the other issue in our age is that if you have an anemia, it will exacerbate your heart disease. Having any kind of obstruction, like you have coronary artery disease, you may start having chest pain, you may start having angina that you otherwise would not have if you were not anemic. That's because you can't deliver enough oxygen to your heart, and because of the obstruction, and you can't deliver enough oxygen to your heart because of the anemia. You bring your blood count up, you can walk much further and much faster than you could when you were anemic. So the anemia evaluation in outpatient, you do the blood tests, you check your iron levels, you check your B12 level, and you sort of decide, you group them in those categories that I mentioned before, and you decide how you're going to treat them. You take us? Yes? No. The answer is no. And there's no herbal treatment for cancer. What nationality do you think has the highest cure rate for cancer? Yes, which agent? Japanese. That guy. Japanese have the highest cure rate for cancer. And the reason they have the highest cure rate for cancer is respect for authority. You tell them that I got these 12 drug regimen, you got to be on this 12 drugs followed by 12 weeks of radiation. They say, thank you, doc. That's what I'm going to do. Okay. What nationality do you think has the lowest? The lowest. Who do you think is going to be? Huh? No, you're wrong. I suckered you on that one. Okay. It's Chinese. And why do you think Chinese have the lowest survival? Because they go to the herbalist first. You tell them they have cancer, they go to the herbalist and they try to get it cured by the herbalist. And when they come back, it's an advanced stage. Okay, all right. Afro-American are closer to Chinese than they are to Japanese. 1/3 of Afro-Americans will seek another opinion from someone other than an oncologist for the treatment of cancer. And that's why this began. I talked to my cousin in California. You go to California, people are in the herbs, okay? Who recommend the herbalist. And he cured a lot of people without chemotherapy or surgery. I hear this all the time. Okay? All right. I've never seen one of those cured people, but I hear this all the time. Okay. The other reason that I can confirm this is that I've sent people for second opinions to Emory, UAB, MD Anderson, Mayo. They never gave them herbs. Not a single person, okay? Iron deficiency anemia is a nutrition anemia. And the reason I'm targeting iron deficiency anemia, in particular in you, is that you have to be aware that all anemias have an explanation. Only people born with anemia are people who have things like sickle cell or thalassemia. If you develop an anemia, it has an explanation, and you need to find the explanation. If it's not iron, it's not B12, it's not folic acid, and you're not drinking, then you need to figure out what the anemia is, which includes doing a bone marrow biopsy to get the result. If you are iron deficient, it's particularly important. In iron deficiency anemia, the blood loss is slow and is inapparent. You're never aware that you're bleeding. Okay. The only way iron can get out of your body is by bleeding. You have the iron that you were born with. You have the iron from your mother in your body right now. Okay. It can only get out of your body if you bleed. Okay. And if the blood is getting together, if you become iron deficient, you have to find out where you're bleeding from. It's extremely important because if you look at a study of men, particularly, who were referred for a colonoscopy because they are iron deficient, 6 out of 100, 6% will have colon cancer. If you just refer, you look at a study where men were referred only because their stool was positive blood, 2% will have colon cancer. If you look at women postmenopausal who referred for iron deficiency, 6% will have colon cancer. If you look at premenopausal women who are menstruating, 0 will have colon cancer. They are iron deficient because of their menstrual periods. Okay? If you look at men referred for colonoscopy who are not iron deficient, almost zero will have colon cancer. So it's the iron, it's the bleeding that tips you off. And you remember that diagram that I showed you before. One of those tests in there. Let's see if I can get back there. This test. One next to the colonoscopy and the one here are both just tests for blood in your stool. And they have a 73% efficiency rate of detecting cancer just for testing for blood in your stool. Okay. So the important thing is that if you have iron deficiency, you have to have a colonoscopy. And if the colonoscopy is negative and doesn't give an explanation, you have to do an upper endoscopy. And the reason you do the upper endoscopy is because you could have also cancer of your stomach, or you can have two other things. You can have H. pylori. H. pylori is associated with iron deficiency because it damages the mucosa and you can't absorb iron. So an H. pylori infection is associated with iron deficiency. And the other thing that's associated with iron deficiency in your stomach is something called atrophic gastritis. Atrophic gastritis is that the lining of your stomach is very thin and not productive because you have an immune reaction. You have an autoimmune reaction to the cells in your stomach. Your stomach gets progressively thin and doesn't produce the things it needs to produce. The significance of having atrophic gastritis is that you have a high risk of having gastric cancer, and you have to be monitored just like a person who has a high risk of having colon cancer. You have to have serial.
Dr. Collins.
Yes.
Give us a second so we can prepare for some questions. Is that okay?
Absolutely.
Since we've got the film crew here also. But Dr. Collins is going to address some questions. I just got a few notes that I want to share with you guys. My name is David Dorban, and I'm the mediator for the the Q&A today. We thank you for being part of this discussion, Dr. Collins. We really appreciate you. And gentlemen, as your questions come to mind, I encourage you to write them down. Every question is important, and every question adds value to the discussion. As you all can see today, the room is full. So I'm asking you just to make sure that your questions are directed toward the doctor, are concise, and they are in the form of a question. We would really appreciate that as far as the time is concerned, okay? Also, please speak directly into the microphone. We've got Brother Roberson here with a microphone. He's going to be working this side of the room, and I'm going to be working this side of the room, okay? And lastly, we value your collective health concerns and your collective health questions. However, we want to keep it to questions today versus commentary or monologue. Is that okay? All right. Well, we'll have time for some monologue and some discussions next month. We've got the doctors won't be in the house that month. We'll be here to make sure that we all can have a good fellowship, communicate, and do what we like to do, man. Discuss among one another. It's okay. We're going to start on this side. Who's got the hand up? First question.
Thank you, Doctor, for your thorough explanation. I'm a heavy drinker, and when you mentioned folic acid and the effects on the bone, can you elaborate a little more on that?
All right. Alcohol is both a nutrient and a drug. It has both effects. You can actually live on alcohol because you can burn it. You can burn it just like you burn sugar. And so that's one of the problems when you drink heavily is you are burning alcohol instead of eating a regular diet. There's folic acid in every leafy vegetable, every green leafy vegetable. The interesting thing about treating patients who have anemia is, particularly when they're hospitalized, they come in for an alcohol-related problem, they'll be anemic, and after they eat one meal, in about 2 days, their anemia starts to go away. That's how little folic acid they really need to get. And so the other problem is that alcohol is a toxin. And some people are more sensitive to others. Some people, it takes 1 or 2 drinks and their bone marrow is wiped out, other people can drink forever and have little or no effect on the bone marrow. So some people, it's a direct toxin on the bone marrow. And other people, it causes a problem with folate metabolism. Yeah.
Dr. Collins, thanks again for being here with us today. One question about blood donations. Can you give us your opinion on donating blood? Your opinion on blood donations? Yeah, so I just wanted to know your opinion on us donating blood.
All right. What I do is I specialize in treating sickle cell patients. I was doing general oncology up until about 6 years ago. And then the director at Grady, who was in charge of the comprehensive center, retired and asked that someone establish another sickle cell home. There are about 10,000 sickle cell patients in Metro Atlanta, and the Grady Center only handles 2,500. So there are about 8,000 people who have no sickle cell home. But what I specialize is in transfusion problems. And we do something called red cell exchange transfusion, in which we will actually take out their sickle cells and give them normal blood. So we can do 7 or 10 units. We can give you 10 units of blood and take out 10 units of blood in about 40 minutes. We have a device that can do that. And we do that for people who have severe disease so severe that it's incapacitating. They can't go to school. They can't go to work. They're having strokes. They're having acute chest syndrome. They can't function normally. And when we do that, they stop having crises. They start having these episodes. And so we do about 1,200 exchange transfusions a year. Sometimes we do them in the middle of the night for patients who come in and having a critical problem. We do them 5 o'clock in the morning. We have our own transfusion team, our own exchange team. The problem is that the more blood you're exposed to, the more you react to blood and you start developing antibodies. About 30% of people, not everybody develop antibodies, 30% of people will start reacting to blood. The more blood they see, the more antibodies they will make. But if they have blood of African, people from West African origin, descendants of people they have less chance that they're going to react to the blood. So there have been several studies that show that if you use blood in sickle cell patients that are from Black people, the chance of them developing antibody is much less. Okay, and so it's very important that we get Black people to start donating blood. And there are a couple of movements now trying to get college students. And I went to Alabama A&M and we usually play Alabama State for which is the largest Black event in the entire country. It's about 500,000 people showed up for it. And they got at least 4,000 donations from college students at that event, which is really important because we really need Black blood in the blood bank. Now, about 90% of the blood in the blood bank is Caucasian.
Got one right here.
Thank you very much. Yes, Dr. Collins, when you get your normal, regular exams doing every year, and your doctor sends you to get your lab work, normally they indicate the kind, the areas that they want to have tested. Are you automatically tested for anemia when you get those annual blood tests?
Usually you are. Usually most people will take get a complete blood count, and they will get a test or a metabolic test to look at your kidney and your liver function. But the one thing they don't get is a B12 level. And they probably should get a B12 level. And the reason you get a B12 level is because B12 can cause neurological symptoms. It can cause problems with your spinal cord that can result in you being totally unable to walk. It can give you peripheral neuropathy. It can cause you problems with your bladder, problem with unable to walk. And the other thing it can cause dementia. Because of dementia associated with it. It can cause a psychosis that's associated with it. And it doesn't necessarily have to be anemic. Sometimes it'll occur in a person who's not anemic at all. They're just B12 deficient and they're not anemic. And so it's probably a good idea for everybody, particularly our age, because the incidence of B12 deficiency gets higher and higher the older you get. A particular person like me who has vitiligo, if you have an autoimmune disease, the chance of you developing B12 deficiency is high. If you have thyroiditis, it's high. If you have lupus, it's higher. One autoimmune disease breeds another autoimmune disease, so you tend to have multiple autoimmune problems. So people with autoimmune problems should definitely be screened. The other people who need to be screened is people who take metformin. Diabetes. Metformin causes excretion of B12 and prevents you from absorbing B12. Now, B12, I didn't get to this point in the lecture, B12 is given as a IM injection, where you can actually store up to 5 to 10 years of B12 in your liver. So it takes a concerted effort over years to become B12 deficient. You've had surgery, and one of the most common things that causes B12 deficient is having bariatric surgery, weight loss surgery. When you bypass the stomach or bypass your small bowel, the duodenal and proximal small bowel, you're unable to absorb B12. So about 5 years later, you're B12 deficient after you've had the bariatric surgery. But the important thing, that's why I emphasize, is that you can get the consequences of B12 without being anemic.
Dr. Collins, thank you. Listen, 2 questions. I have ankylosing spondylitis. Do I need to take iron? Because I've been having ankylosing spondylitis since I was 20 years old. I have bamboo spine. And the other question is, you said that if you drink coffee or tea hot, that you would likely develop cancer. So how many cups of coffee or tea can you drink?
All right, well, I had 2 cups myself today. A cup of coffee. I said that there is a statistical relationship. I didn't say there was an actual causation. The statistical relationship means they did a survey of people who were drinking coffee and had cancer, and they linked the coffee and the tea, hot coffee and tea, to esophageal cancer, gastric cancer, but no other cancer at all. They did 2 separate studies have shown that. But in order to make that causation, you have to do a prospective trial. You have to take 10,000 people who drink coffee and 10,000 people who don't drink coffee and follow them for the next 15 years to see whether there's a relationship. The difficulty is finding 10,000 people who don't drink coffee. Okay. All right. So, but that's the way you determine whether there is a causal association, not just a statistical association. Okay. So I'm not going to give up a coffee.
Yeah, listen, gentlemen, we've got a lot of good questions, very dynamic discussion here. Obviously, Dr. Collins is not going to be able to answer every question today, but we're going to get as many as we can in the next few minutes, next about 5 minutes. Okay, we've got one over here, Dr.
Collins. Dr. Collins, my question is the toxin environments. One, I know Agent Orange, maybe the burnt pits. Is there any correlation in terms of leukemia causing cancer in those type of studies?
When I was a resident at the VA here in Atlanta, we saw guys coming in with these strange sarcomas. And I was working with a guy named Ravi Samra, and he was a brilliant oncologist. And Ravi kept saying, I've never seen these sarcomas before, ever. And we need to look them up. So we looked them up, and there would be like 5 in the country. And we would have 3 in the clinic. And so we said, well, there's something going on here. And then at the same time, we saw the Agent Orange discussion going on in Congress and the denial that it was causing a problem for years and years, when we knew that these people we were seeing were not normal. It was not usual. It will take years to see the effect of the burn pits. It will not be something you will go in and say, burn pits cause this. 20 years from now, you need to see, follow the people who are in the burn pit to see what they have. It took almost 20 years to see the results of Agent Orange. Okay? It takes almost 20 years to see the result of almost any carcinogen. When you smoke, you don't see the result right away from smoking. But 20 years later, you start to see the results of smoking. And then the more years you get away, the more results you see. So I think that the jury's out on how bad the burn pits are going to be. The Agent Orange definitely is a causation of malignancy, a causation of immune disturbances that I've been aware of ever since 1978.
All right, got one over here, Dr. Collins.
Yes.
Give me just a second. We'll get back over to you.
Dr. Collins, what should your signs be when you have blood in your urine? You talk to your urologist and he says, don't worry, that's just something old people have. And, and then don't pick up anything heavy, because it increases the amount of blood in your urine when you pick up heavy stuff.
Okay,
is it related to prostates or what?
I can't answer a personal question. I can answer it in general in terms of blood in your urine. There is one of the common reasons to have blood in your urine, and when all your tests are negative, is having a sickle cell trait. People with a sickle cell trait, unless your urologist has checked for the sickle cell trait, that's always a possibility. Sickle cell trait has no symptoms. You don't have any symptoms of sickle cell disease. But one of the things you can have is bleeding in your urine, and that bleeding in your urine can last for a few days to a few years. You can just keep bleeding and bleeding and bleeding. I actually had to do a nephrectomy once because the bleeding wouldn't stop, and nothing we could do would stop it. We actually had to remove the kidney in order to stop this bleeding from going on and on and on. So the bleeding from a sickle cell trait family. The other thing you're always concerned about with any type of bleeding in the urinary tract is whether you have cancer. So if you've done the cysto, you've done the MRI, you've done your retrogrades, and you don't see cancer, and it's been going on all for years, that's a good thing. It's a good thing because you have looked for the cancer and you don't have cancer, and now the bleeding in your urine is an annoyance. And if you take iron, you can keep up with it. You won't get anemic even from the bleeding until you run out of iron. So if you take iron, you can keep up with it. Other things they can give you what looks like blood in urine, but it's not really blood in urine. It's just hemoglobin in your urine. One thing is very active people, marathon runners and joggers, will have hemoglobin in the urine from the trauma on their feet, the smashing blood cells on their feet, and they will end up with hemoglobin in the urine. The hemoglobin in the urine is dark. It is dark, look like maybe, I would say, you can get it dark as coffee. Okay, and so you can have things unrelated to your kidneys that turn your urine dark and make it look like it's bleeding in urine. But the important thing, if your urologist has done the retrograde, he's done the MRI, he's done the cysto, and you don't have cancer, that's what you want to know. Just take your iron and keep up with it. Okay.
Hey, Dr. Collins, thank you. Is there any correlation between arthritis and anemia? Arthritis and anemia, is there any correlation?
Yeah, arthritis, it depends on your arthritis. Inflammatory arthritis, like Reiter's syndrome, like gentleman with ankylosing spondylitis, which is an inflammatory disease, or rheumatoid arthritis, is associated with anemia. And I could tell you before, your body, once it gets inflamed, it sequesters iron. And when you did a bone marrow on a person with rheumatoid arthritis, it'll be full of iron, but the iron is all in the immune cells, none in the red cells. So they have iron, but they can't use it. They can't use the iron that they have. And so in rheumatoid arthritis, the activity of the disease can be monitored about what your blood count is. And once your disease comes under control, it comes back up. Most of us have osteoarthritis. You worn out your knees, you worn out your shoulders just from getting old. And that is not an inflammatory disorder. And that should not be associated with anemia. So you would never attribute an anemia to osteoarthritis.
I got two right here. That's it. Hey, Dr. Collins, thank you for your time. Got a question for you. I was born with the G6PD deficiency trait, and my daughter obviously was born with it. I'm 45. I've naturally had a low white blood cell count. As I get older, I don't know what things I should be looking out for, but my main concern is, my daughter. Neither of us have sickle cell, but just want to make sure that, I can take precautionary measures for the both of us.
All right. G6PD is an enzyme. The enzyme is involved in the glutathione system, and glutathione is a protein that is involved in free radical management in your body. When you oxidize fat of any type, you create free radicals. Free radicals is probably the reason you age, probably the reason you develop disease. It's essentially human rust. It causes human rust. And you have a system for destroying. One of the worst free radicals is a superoxide, and it's H2O2. And glutathione changes, let's say, superoxide into water. It takes H2O2 into H2O, and that's what it does. So glutathione is essential. So in G6PD, you have a disorder where you cannot regenerate glutathione, and you get a oxidative injury to your blood cells. So your blood cells start to get injuries to the wall and injury to the protein from oxidation inside the cell. When your spleen is an organ that filters your blood, it takes out any damaged blood cells. So when your spleen sees that injuries to your cells, it takes them out and it destroys them. So you have an anemia because of the G6PD causing an oxidative, the actual G6PD causing an oxidative injury, and your spleen is constantly destroying your blood cells. But it can be aggravated by anything that increases your oxidation level. And these are drugs primarily. The G6PD was first discovered after full integration of the military, and black soldiers were sent to the tropics and they were given primaquine, a treatment for malaria. And when they were given it in California, but before they could get to their destination, they would be faint. They would become jaundice, they would pass dark urine, and they would feel faint. And that's because they have activated their G6PD and hemolyzed their blood. So it was discovered that this is once again, a West African trait, an African trait that gives you resistance to malaria, but in the absence of malaria, in terms of disease. What I advise people to do who have G6PD is to treat it like an allergy. When you go to the doctor, or you go to a new doctor, or you go to the pharmacy and you fill out the form where it says allergy, even though it's not an allergy, put G6PD. The computers will automatically screen all medications for it. The other thing that would activate your G6PD is having a fever. And finally, one thing you have to be careful about, if you're into Mediterranean food, there is a bean called a fava bean that can cause you to have severe anemia. If you have G6PD, it's called favaism. And I've seen it. I've been to a Mediterranean restaurant and they looked at the salad and they have fava beans in it. So if you have this disorder, if you eat a salad or you eat at a restaurant and you start passing dark urine, you possibly have G6PD.
Dr. Collins, thanks for being here and informing us with all this great information. Two questions. Sickle cell, is there a trait or a test to see if you have a trait? I've been told I have a trait, but is there an actual test I can take? And secondly, how do you get your, what's the intent, how can you intentionally oxygenate your blood? Oxygenate your blood, get more oxygen in your blood.
Okay. See, usually when you're screening for sickle cell, you do what's called a solubility test. And that solubility test will tell you whether if you take away the oxygen, then the cell will spontaneously sickle. That doesn't tell you whether you have the disease. That tells you that you have a gene. In order to know whether you have sickle cell disease, you have to do what's called a hemoglobin electrophoresis. And the electrophoresis separates out the hemoglobins. So if you have a sickle trait, you should have hemoglobin A 50%, hemoglobin S 50%, and that's a trait. There are some people who think they have a trait, but they actually have the disease. Some people have what's called SC. And SC, they have 50% S and 50% C. They have no A. That's actually sickle cell anemia. The other thing that's confused with sickle cell anemia is something called sickle thalassemia. In sickle thalassemia, you have some A, not 50%, maybe 20, 25%, but you have 70% S because the thalassemia gene doesn't put out enough hemoglobin. So you have, anytime you get over 50% S, then you have a disease. Okay. All right. And I'm not sure what you mean by oxygenating. The oxygenation of your blood is a function of how well your heart and your lung works. Okay, oxygenation is, the thing that can keep you from oxygenating your blood is smoking. People who smoke and have an increase in carboxyhemoglobin, they also have a decrease in the amount of oxygen that's in their blood. And I'm interpreting from your question is there a way to get more energy from no, not really. People, blood doping is a form of cheating. When you're like doing the Tour de France, you tolerate high altitudes and exertion better if you have a slightly more blood, but it's also detrimental in the fact that if you have more blood, you predispose yourself to blood clots, you predispose yourself to strokes and to heart attacks if you do it. So it's not a long-term plan or a long-term strategy. One of the other things that I see all the time is people requested B12 because they think B12 give you energy, and that's not true at all.
Well, let's give Dr. Collins a big round of applause. And I think he said he might hang out with us for a little while. So I hope you've written your question down. We're coming up, gentlemen. We want to just acknowledge you all and let you know that the Minority Men's Health Discussion is coming up on its 2nd anniversary. Can you believe it's been going for 2 whole years continuous?
James Freeman and Danny Bugs. James Freeman and Danny Bugs. Okay. Joseph Council White and Dr. Richard Tyler. Philip Jackson and Lavelle Thornton. Philip Jackson and Lavelle Thornton. Okay, I think it's Jimmy Littles III. Jimmy Littles III and PJ Johnson. Jimmy Littles III and PJ Johnson. Okay. And finally, no, there's 2. Larry Frederick and Ralph Brannon. And the very last one, Gerald Evans and Eugene Ferguson. Good. All right, last call. If you fill this out, put us straight to high. Okay. Okay, ready. Thank you all. This is your end game here. John. No.
Hey. First of all, I want to say thank you for coming. All you men in the house. The new people, the rule is go at your own pace. If it's something you don't want to do, don't do it. But if
that's all we have left.
The doctor says don't do it, do a little bit.
You need, exercise makes everything work. It goes to your brain, it goes to your groin, it goes everywhere, right? Exercise, right? Right?
Now, every motion that I'll be doing, I'm symbolizing something in a gym. We'll be working those hip flexors, those quads, those hamstrings. Y'all know we're going to get them abs. And most important, cardio is life. So let's get ready. We're going to create that circulation. Working on something new. Sure. We need that blood circulating. Ain't nobody like my father. Yeah. I like my father. Yeah. I like my father. I like my father. You know it out. You know it out. You know nobody. Gonna feel like that. No. Get on my bed. Come on. Go, boy. Look out. Nobody wanna do that. When I had a lot of power, now I got a lot of hands on my time. And everybody wanna be a friend of mine. I need these abs. I know y'all do this. Oh! We about to get them out. Right in the lotto.
You want to put John up there?
Oh, no! Oh!
She wants you to put John up on the
Fred! Some people got to have it.
Recording in progress.
I did that.
Just rock with it. Go that way. Something's gotta work. Oh, I don't know myself. Come on. Feels like I'm on the wrong pole of it. The devil's not here at my door. Whoa, I'm behind. How many times did I tell you how good it is? It's taking a toll on me. Try my best to keep from tearing the skin off my bones. Don't you know? Lose control. I'm falling apart. Lose control. You're breaking my heart, baby. Happiness, I want you better than feel like how you gonna look there? Come on. Looking back. Right back. I told myself time and time again, but another fight, things ain't right, and I'm losing. It takes a fool to lose fight. It's how I worry. Since I got you. I think one of my favorite songs. You're not trying to lie. How you gonna find out? I'm always doing work. Watch this here. Come on. Get him up. That's it right here. Work the mountain. Go get that other body. Big back. Big chest, let's go. We get that in mind. Watch, watch. Sit back. Get out there. Watch. Come on. We get big leg. We get them
Thank you, John.